So there is another entity, that is endothelial dysfunction. So it has been reported that reduced endothelial dependent flow mediated dilatation, okay, of the brachial artery was detected in patients with coronary slow flow phenomenon, suggesting that endothelial dysfunction is implicated in the etiology of the slow flow phenomenon. Then noteworthy is the recent finding demonstrating that baseline and peak exercise endothelin 1 plasma concentrations were higher and nitric oxide plasma concentrations were lower in slow flow phenomenon. So in addition, patients with slow coronary flow had raised level of plasma homocysteine and asymmetric dimethyl arginine, a nitric oxide synthase inhibitor, both of which have a detrimental effect on the endothelial function. And more recently, they've seen a decreased adiponectin concentrations and peroxidase activity. These two are significant markers of endothelial dysfunction. And these were also shown to be responsible for the etiopathogenesis of this coronary slow flow phenomenon. And subclinical atherosclerosis. Utilizing IVUS technique. You know IVUS? IVUS is intravascular ultrasound. Uh, just as how you do an external ultrasound, within the coronaries, we use this intravascular ultrasound and we pass this through the coronary vessels. And after passing through the coronary vessels, we assess how the lesion is, like how the stenosis is, how the thrombus is, how the vessel wall is. So we use that IVUS. And in a similar way, utilizing this IVUS technique and the flow rate measurements, Sim et al., they have demonstrated that the patients with coronary slow flow phenomenon have diffuse intimal thickening, and there was a widespread calcification along the coronary vessel wall, and non-obstructive atheromatous coronary changes were there. Inflammation again. So another group, Lee et al., they showed that the plasma concentration of high sensitivity CRP and interleukin 6, these are inflammatory markers, they were increased in the slow flow patients. Similarly, coronary slow flow was associated with higher levels of plasma soluble adhesion molecules, including the intercellular adhesion molecule 1 and the VCAM, vascular cell adhesion molecule 1 and E-selectin. Other inflammatory markers such as red cell distribution width and serum uric acid levels were also shown to be correlated with the slow flow phenomenon. If you are well versed with the inflammation process in the pathology, you'll be knowing about all these things. Then in humans, no reflow is caused by a variable combination of four pathogenic components, and they are distal atherothrombotic embolization, ischemic injury, reperfusion injury, the susceptibility of coronary microcirculation to injury. Distal embolization. Okay, emboli of different sizes, they can originate from the epicardial coronary thrombus and from fissured atherosclerotic plaques, in particular during PCI. Then experimental observations have shown that the myocardial blood flow decreases irreversibly when these microspheres obstruct more than 50% of the coronary capillaries. So if you see this image, there is a stent which is placed at the proximal part. If you can see this, that is stent balloon, and there is atheromatous process, and you can see those particles. They are embolizing towards the distal circulation. You can see the distal circulation, and this is the coronary microvascular component. So these particles, they get embedded in the coronary microcirculation, and that is what is known as distal coronary embolization. And then you have the secondary inflammation, and then you have in the bottom of the picture you can see that there is spasm within the vessel wall, that is microvessels. Okay, so there is microvascular spasm. So ischemia related injury. So changes in the endothelial cells, they are visible after prolonged ischemia, are represented by endothelial protrusions and membrane-bound bodies. So which often they fill the capillaries up to luminal obliteration. So furthermore, large endothelial gaps with extravascular erythrocytes are common, and morphological findings are accompanied by a reduction of regional myocardial blood flow within the previously ischemic region. And moreover, myocardial cell swelling is associated with interstitial edema that might cause microvascular compression. So just note this reperfusion related flow chart. So there is massive infiltration of coronary microcirculation by the neutrophils and platelets at the time of reperfusion. Sai Ravshankar sir has joined the session again. So there is subsequent adhesion to the endothelial surface and migration in the surrounding tissue. Then release of oxygen-free radicals, proteolytic enzymes, and pro-inflammatory mediators, leading to tissue and endothelial damage. And then finally, vasoconstriction released by damaged endothelial cells, neutrophils, and platelets. So there is sustained vasoconstriction of this coronary microcirculation. Neutrophils also form aggregates with platelets that plug the capillaries, and thus mechanically they block the flow. So this is the diagram which is explaining you. Look at the capillary lumen and there are endothelial blebs there. Then you have the regional endothelial swelling, and these are obstructing the flow of the RBC, which is shown in the diagram. And then you have platelets which have adhesed. Then neutrophil plugs. Then you have the swollen myocyte which is compressing the blood vessel externally. And then you have the luminal narrowing. So once this swollen myocyte is compressing the vessel, you can see the luminal narrowing, and then you have the Rolex formation of the RBCs and then microemboli. So individual susceptibility. Who are all the patients who are going to get this coronary slow flow? So if at all, if the individual is a diabetic patient, or whether there is any new onset or any acute hyperglycemia, and patients with high cholesterol levels, hypercholesterolemia, and lack of preconditioning, ischemic preconditioning, and these are the patients, they are prone for this coronary slow flow phenomenon.
A long-standing diabetes patient is always the blood supply also, the coronary blood vessels also will be thinned out. So they are very susceptible for the slow flow. And the recent observation also shows that CT angiogram demonstrate that patient with CPFF, the angulation of the main coronary artery from the aorta were similarly determined. So the anatomical factor also one of the important for the coronary slow flow. So the predictor of the, so who are they? Which I have told there is a primary PTCA which you are doing. The thrombus burden is more, even though if you do the thrombosection and the dilatation also, there will be some distal embolization. So when there is a thrombus burden is more, distal embolization will be more. Then the ischemic duration, if you are doing in a golden hour, or if you are doing within 3 hours or within 6 hours or within 12 hours, that is a organized thrombus. Organized thrombus, again, there is a chances of slow flow is very common. So if the ischemic duration is more, ischemic extent is more, a large thrombus, like interval MI, extensive interval MI, LAD is totally thrombus, these are very prone for the slow flow. Again, reperfusion, neutrophil count, how much, if the neutrophil count is more, ET1 level, thromboxane ALT level, and mean platelet volume reactivity also, that also predictor for the slow flow or no flow. And those already we have discussed, diabetes, hypercholesteremia, and lack of precondition. These people are very prone for the slow flow or no reflow. So these are the few conditions where interventional distal coronary embolization, microvascular obstruction, inflammatory response, and secondary ischemia, reperfusion like ischemic reperfusion injury, myocardial edema, endothelial swelling, all these things, and duration of the preceding ischemia, all these things are predicted for the no flow or reflow. So secondary slow flow condition, few of the condition where coronary artery is abnormally high, like ectasia, coronary spasm, coronary stenosis, embolism, heart failure, heart pumping action, LV dysfunction, angioplasty and stenting, valvular heart disease, connective tissue disorder. These are the very condition associated with secondary coronary slow flow. So manifestation, angiographic observation reported incidence of almost 1 to 5% in patient undergoing diagnostic angiography, and the phenomena most commonly in young patients actually where there is a smoking and there is more thrombus burden is there, patient admitted with acute MI, and clinical course patient, 80% of the patient experience the recurrent chest pain most at the rest, and may require ICU admission. Metabolic syndrome also very common with the slow flow, presence of higher total cholesterol, low density LDL cholesterol, and fasting glucose, high glucose level, and high BMI levels also are prone for the slow flow. And observation, insulin resistance is one of the important factor for the. So all these things, before taking to the patient to the cath lab, you have to ask the history detail, how much and what are the clinical history and the clinical parameters, blood pressure, all this, and the associated lab investigation you have to see before taking to the cath lab, so that mentally also you are, yes, this patient is prone for the slow flow. In cath lab, angiographic or Doppler wise, you have to see finally TIMI, either you are getting TIMI 3 flow or TIMI 1 or TIMI 2. And post discharge, you have to see the lack of myocardial contrast opacification. And if you can do the even scanning, gadolinium enhancement scanning also you can do. So TIMI 0 flow means it is absolutely referred to absence of any antegrade flow beyond the coronary occlusion. TIMI 1 flow means faint antegrade, which already. Now we can have some discussion regarding this. If you have any questions or anything, let me know that we can discuss that.
Doctor?
Yes, sir.
Yeah. Based on your lecture, I conclude that if we want to diagnose or to make sure there is the slow flow phenomenon, it's based on our angiographic examination.
Correct.
Or in daily practice, we can face the patient with this slow phenomenon, coronary slow phenomenon, in our daily practice.
So, which one you are giving? When you see that there
I
is
mean, are there any clinical manifestation in our practice every day?
no, in any coronary no flow or slow flow, if you put the stent and after that there is a TIMI 0 or TIMI 1 or TIMI 2, that is called slow flow, TIMI 1 and 2, and TIMI 0 is no flow.
Okay.
In that case, this is the what, how to do. Patients are very prone for the cardiac, the muscular cellular level, this cardiac muscle will be deaf. So in that case, you have to treat it vigorously. Whether you give pharmacological agent or whether you give the thrombosuction and aspirate as much as possible distally, you have to take the thrombosuction catheter up to the distal coronary. You have to suck it so that at least some amount of thrombus will come out. And you have to vigorously give the GP2B3A inhibitor so that the flow, the coronary perfusion will be more. So patient will have a dilated, the coronary artery, the flow will establish.
Okay. So we just the things the patient with the factor risk or predictor risk, and then we have to predict it. Maybe there is
before taking the patient to cath lab for primary, mostly coronary flow, if the sugar level are fine or not. In an elective patient, you have to see. Mainly what we encountered in a primary PCI. So we regularly do primary PCI. In that case, so if you are not establishing the TIMI 3 flow, or you are not getting, you dilate it, you thrombosex it, then you have to find out the flow. Then only you can put the stent. Otherwise, the whole vessel will be blocked.
Okay. Okay.
So
Thank you.
before taking the patient, properly dehydrated or not, number one, sugar levels are fine or not, hemoglobin level are fine or not, all these things, minimum basic investigation, then yes, chances of no flow, reflow will be there or not. So
Yeah.
before taking to cath lab, you have to see these are the parameters.
Okay. Thank you, doctor.
One again, so all CBP, hemoglobin, sugar level, creatinine level, and the LV function, These 400% you have to see before taking to cath lab for the intervention.
Yeah. Okay.
Thank you, Mohammed.
Yeah.
Who is this?
Sir, Dr. Enamul, sir.
Yes.
Sir, we found that during PCI, if there is coronary slow flow or no flow, we are doing some measure. We are taking some measures. But after successful completion of stenting or balloon dilation, procedure we are doing some management. But after procedure, is there any effect of this coronary slow flow or no flow, or what are the management we should give the patient to overcome those situation post PCI?
Very good question. Actually, when you are doing the primary PTCA or any PTCA, you have to see whether it's the lesion is a burden of thrombosis, how much. It is a calcified lesion or a thrombus lesion. If it is a no flow, is very common with burden of thrombus is very high. Even though you may get a calcified plaque, the calcified plaque also can block the coronary distal circulation. So that is one. Mostly 90% it will have when the thrombus burden is low. So there is a plaque is there already ruptured. One more plaque, if you are rupturing, the thrombus burden will be more. You got it? There are two plaques are there in coronary artery. Here one, here one. So if you are occluding this, and you are by doing the balloon also another plaque, so thrombus burden and more. By chance in the cath lab you got TIMI3 flow. So your question is how to handle the post PTCA in ICU. If the thrombus burden is more, 100% you have to give nicorandil, coronary vasodilator. Second, you have to give GP2B3A inhibitor. So normally we give 8 to 10 ml per hour. Into 24 hours we have to give. Tirofiban is very cheap. Epsepsimac also you can give either. So one, I have told you nicorandil. A bolus dose followed by injection. Second is GP2B3A inhibitor, and proper heparinization also essential. Either you give unfractionated heparin 1000 units per hour or 5000 units 6 hourly, or you can give enoxaparin 60 milligram BD subcutaneously. So plus all antiplatelet, the rosuvastatin, ticagrelor, leucosprin have to be very, very clear. We have to give. If you give all these things, there is a fair chances of 90% chances that patient will not develop any problem. I hope.
Understood, sir.
Right. Thank you. Okay, sir. Yes.
ఇది రమాదేవి అనే పేషెంట్ అంట సార్ ఈపీఎస్ ప్లస్ రేడియో ఆపరేషన్ గురించి
చెప్పండి ఎవరు వాళ్ళ ఇన్సూరెన్స్ ఉన్నది ఆ ఇన్సూరెన్స్ ప్రకారం వాళ్ళ బైక్ లో వచ్చారు ఈపీఎస్ 3D మ్యాపింగ్ విత్ ఆర్ఎఫ్ఐ లేదమ్మా నాకు 1.8 lakhs అవుతుంది 1.8 lakhs అవుతుంది ఇన్సూరెన్స్ లో మేము అప్లై చేయవచ్చు 100% విల్ గెట్ ఓకే ఓకే ఎస్ డాక్టర్ I hope it is clear. What we are dealing with is a coronary flow is a very flow or no flow is a very important day-to-day complication. So how to deal with this, you have to understand that. Any other questions? If no other question, we'll take up one more. Then first basic complications like dissection. Next we will discuss about the dissection and coronary dissection. What are the types of coronary dissection? How to do that? Coronary perforation, how to handle this, and we'll discuss one by one. I hope by that we can cover up all the complications of the and coronary bifurcation stenting also we'll discuss one. Okay.